All right. Good morning. My name is Puneet Dhillon, and I'm the CEO and chairman of Skye Bioscience. Welcome to our first dedicated obesity-centered KOL event at Skye. Today, we will explore our strategic approach to combating obesity through metabolic rewiring with CB1 inhibition. Obesity is a critical public health issue, and that's requiring very innovative solutions. At Skye, we're committed to developing groundbreaking therapies, as well as setting the benchmark for how our industry and stakeholders follow along on development plans. And one of the core purposes of the timing of today's event is really to establish that clear roadmap for our stakeholders, and also the other one is to be educational and informative to learn how CB1 inhibition is a promising mechanism of action for treating obesity and other metabolic disorders. This is a reminder that Skye is a public company. We will be making several forward-looking statements today. Please review this disclaimer and risk factors disclosed in our SEC filings before making an investment decision. All right, let's review today's agenda and objectives. I'll serve as the moderator today, and we'll start with a brief introduction and overview, followed by insights from leading experts on the urgent need to address obesity within our healthcare system. Our speakers will present the scientific rationale behind our CB1 inhibition strategy, share clinical experiences, past and present, and discuss the nimacimab phase 2 clinical trial design. We'll then engage in a panel discussion and Q&A session to address your questions. At Skye, our mission is to develop innovative medicines that enable better health and quality of life for patients that are struggling with obesity and metabolic diseases. Today, we're putting our stake in the ground about being a pure play metabolic company, a journey we began approximately 1 year ago. By harnessing the cutting edge research and technology that we're working on, we aim to create a differentiated and transformative type of treatment that makes a global impact. Our mission and vision reflect our determination to lead the field in metabolic therapeutics with innovative science and a commitment to patient health through scientific and operational excellence. Today, we have our executive team present, as well as experts in the obesity and metabolic field. Each of the key opinion leaders on today's panel bring a unique perspective in treating patients with obesity, as well as the science involved in the complex circuitry of our metabolic pathways. Their proven track record and respected voices in the field underscore our commitment to have an authoritative voice and approach to tackling obesity as a disease through all the work that we're doing, without a bias and letting the science and data really do the talking. Each of the members' unique expertise enhances and builds on the topics being covered today, and we hope by the end of the session we see alignment on CB1 inhibition being a very important target in the anti-obesity medication landscape, as well as the strategic direction for Skye. All right, so Skye is really strategically positioned to evolve into a fully integrated metabolic company, and we've already leapfrogged on several of these areas this past year to competitively situate nimacimab's clinical development plan. Our robust intellectual property with composition of matter is into 2037. This comprehensive development strategy, an experienced team that really empowered to drive nimacimab through the clinical development steps. And despite a non-traditional capital markets path, we have a solid funding track record, a cap table comprising of the most experienced and successful investors and shareholders in our industry, and now collaboration with world-leading obesity experts. We're really well equipped to achieve significant milestones. So let's discuss these milestones and how they look over the next 3 years. Our vision for 2027 and beyond is ambitious, but it's attainable. And it starts with initiating a robust phase 2 proof of concept obesity clinical trial this coming month, followed by generating interim and top-line data from the study throughout 2025. The interim results really allow us to pull the lever down on accelerating the phase 2b start and potentially expanding our metabolic franchise. And ultimately, if we're just sticking to the primary obesity program, our goal is to be a phase 3 ready company by the end of 2027. Nimacimab represents the future of metabolic therapeutics, and there are 6 attributes we want you to pay attention to in the presentation today that are the basis of the scientific and clinical strategy and really designed to shape the optimal metabolic product profile. In some of these areas, we've already set the benchmark with the quality of the data generated to date, such as in safety and tolerability. What's ahead is demonstrating that nimacimab offers a clinically meaningful weight loss, similar to how the CB1 inhibition class has demonstrated to date. As well, we want to show preserving muscle mass is better than the alternative mechanisms of action, and the potential for long-term dosing without adverse neuropsychiatric events. And together, all of these attributes really position and may position nimacimab as the leader in the field. The current clinical trial and overall obesity development plan is designed to really highlight the hypothesis represented by this illustration, that nimacimab's improved tolerability keeps patients on drug and promotes sustainable and healthy weight loss while preserving muscle mass, and that the current anti-obesity medication landscape will really evolve towards requiring an additive mechanism of action, such as nimacimab, to address really the heterogeneity in obesity. So later in the presentation, when we cover the phase 2 trial design, you may want to keep this visual as a reference regarding the objectives of our study. We also remain committed to operational excellence, and we're prioritizing internally the establishment of those kind of benchmarks that really enable us to exceed or outperform industry standards in both speed as well as capital efficiency. So what we mean by that is in the last year, we've completed the acquisition of Bird Rock, actually on August 21, 2023, and then we secured an IND for the obesity study, as well as the funding to advance our development plan in Q1 of 2024, among some of the other capital markets objectives. And now our clinical drug and clinical trial are ready to come online, which the team has been working hard on over the last 6 months, and we'll initiate enrollment in the phase 2 study next month, which is really kind of highlighting one door opening to a new door in exactly 1 year. So you can expect that momentum to really build now on our development plan with the same attention to detail. And although it's in our ethos to proceed cautiously and continue to manage our capital allocation, the current phase 2 study really, the results from that phase 2 study, as well as other milestones that we're working on, certainly may catalyze the growth of our metabolic franchise. So nimacimab's unique attributes, including the high selectivity, extended half-life, and multifaceted metabolic benefits, really make it a cornerstone of our therapeutic pipeline. And these strengths position it for an application in other metabolic disorders. And as I stated earlier, we're waiting on additional data based on preclinical and clinical studies before adding to the clinical pipeline. All right, so I'll turn it over to Dr. Lee Kaplan now, who's providing an overview of why treat obesity in the healthcare system.
Good morning, and thank you. It's a pleasure to join you all, and my job today is really to talk about obesity and why we even consider it a disease. I'm not going to get into a lot of technical detail here in this 10-minute talk. What I'm going to try to do is make the same case that we make to regulators and that we make to patients and their families about the appropriateness of viewing obesity as a disease by asking the question, why should we treat it in the healthcare system? And well, let me get started. Sorry, I don't appear to be controlling the slides very well. Here we go. So the question is, what is obesity? Well, the World Health Organization says it's a disease characterized by abnormal or excessive fat that presents a risk to health. But when we talk about abnormal fat, there are a lot of diseases that are associated with abnormal fat, which we're not going to go into today. So I think it's more important to emphasize that it's abnormally placed fat. Fat in the liver, fat in the pancreas, fat in the kidney, fat in the heart, et cetera, or excessive fat, or both. More commonly, we describe it as a complex, chronic, and progressive disease. I'll say possibly progressive because we don't really have a way of measuring progression. All we can do is measure the severity of obesity. It's like the old days in diabetes before we could look at beta cell function. What we did was we just measured the glucose. But unfortunately, that doesn't distinguish between progression of disease and failure to control the disease. And the history of obesity care is that we've not been very good at controlling the disease. So we think it's progression, but maybe it's just failure to control. The newer medications that have emerged and the ones that we're going to talk about today, or the one that we're going to talk about today, perhaps will give us that level of control that will really be able to distinguish progression. Now, why is obesity a disease? Is it a disease? Because it results from abnormal metabolic regulation. Yes, there is environmental influences. I'll talk about them in a minute. Yes, there are genetic underpinnings to it. But at the end of the day, no matter what the cause of obesity, it is an example of dysfunction of the system that normally regulates body fat. And just to give you a sense of this, we have an epidemic in the world today of peanut allergies or nut allergies. We know that's from a change in the environment, perhaps too clean an environment during early childhood development over the last 50 or 60 years. But when somebody has to carry an EpiPen in order to protect themselves against nuts, that almost definitively proves that there's something wrong with their immune system. And in the same way, although obesity, the epidemic, is caused by changes in the environment, it's changes in the environment that disrupts the metabolic system as opposed to the immune system, which is what happens with allergies to nuts. Alone, without any complications, without diabetes, without heart disease, it causes pathology and it diminishes health. It's a risk factor for more than 200 other diseases, so it's very dramatically a risk factor, but by itself, it's a disease. But whatever the causes, as I mentioned, the final common pathway of obesity is internal to the body of the person who has it and reflects this disordered or disrupted physiology. So the fundamental question is obesity a disorder that's best treated within the healthcare system? Or as it has been done for the last 70 years, is it best treated in a commercial environment? Is the clinic the right place, or is the strip mall the right place? So let's think about what the purpose of healthcare is generally. The purpose of healthcare is to relieve suffering arising from disturbances in the human body. Those disturbances come from symptoms. If you have a headache, if you have nausea, if you can't walk. They could come from disability generally. And most commonly, they come from fear of complications or of dying, of developing a disability in the future, or just simply of not being able to participate fully in the world around us. Well, obesity causes suffering in all of these ways. It has symptoms, it creates disability, and it certainly creates fear. Relief of suffering from obesity-induced symptoms and fear falls squarely within the responsibilities of normal medical care. So regardless of whether you call it a disease, it meets the criteria of why we in the healthcare system should be treating it. Now, as I've already indicated, there is a physiological process that gets disrupted in obesity, and you should know that body fat mass is physiologically regulated. When babies lose baby fat, it's because the body wants to get rid of baby fat and put the fat, the storage system for our energy, in a different place. There are fat changes with puberty, with girls increasing their fat, boys decreasing their fat slightly. There are fat changes with aging and menopause. Most dramatically, there are fat changes during and after pregnancy and lactation. But in each of these situations, actually where the fat primarily localizes is different. So as you decrease your fat in one place, you might be increasing it in another, and vice versa. At any given time, fat mass is defended by metabolic adaptation, which means that if you have an acute injury or illness and you lose fat, if you had COVID, if you had the flu, you might lose some fat, lose some weight. As soon as you recover, the body is going to put that weight back on, that fat back into your system so that you're ready for the next episode. You'll also see that after you acutely overeat, such as during Thanksgiving and Christmas, soon thereafter, you'll actually lose that extra weight without even trying. Yes, you will have stopped eating for Thanksgiving and Christmas, but you will do it. You'll lose that extra weight without trying because the body, again, is over where it wants to be, higher than where it wants to be. And the same thing happens with calorie restriction. It's like a disease in the sense that the body views it as an inappropriate loss of weight, and so it fights it. And that fighting process is whoops, sorry, it's going the wrong direction here. Sorry. That fighting process is the process of metabolic adaptation. And obesity occurs not because we overeat, but obesity occurs when this regulatory system that determines where and how much fat you should be storing at any given point in your life is inappropriately high. When the body wants to have too much fat, when it wants to have fat in the wrong places. So this metabolic adaptation process is a process whereby the body gets hungrier when it wants to gain weight. It conserves energy, and the energy that it conserves is not energy from running around, it's energy that generates heat. So it's thermogenic energy. And of course, it increases hunger, but it also decreases fullness, satiety, satiation, and the like. These changes are mediated by a very complex regulatory system that we're not going to go into today that includes multiple gastrointestinal and central nervous system hormones, including ghrelin, peptide YY, the others shown here, and some that I'll talk about in just a few minutes. This process, when you simply constrict your food intake, when you simply restrict the calories that you consume, will lead to the regain of the lost weight. And it works in both directions. If you have a skinny kid and you try to fatten him or her up, what will happen is the body will resist that as well, because the body for that particular child wants to stay thin. And of course, there are adults who have the same issue. So it works in both directions, but very few of us tend to feel or be underweight. And because very few feel underweight or are underweight, there's a sense that it's easier to gain weight than lose weight. That's because 40% of the US adult population is on a diet at any given time. So they're actually, that diet is calorie restriction, and so they're below where their body wants to be. So of course, if you're below where your body wants to be, it's very easy to gain weight. So in obesity, the target fat mass, how much weight or how much fat your body wants to have at any given moment, is elevated inappropriately by a lot of changes in the environment. And it's not just one change, it's a whole constellation of changes. I would call it the perfect storm for generating obesity. And if you have a tendency to develop obesity because of a high-fat diet, you have a high-fat diet available to you. If you have a tendency because of a highly processed food diet, the same thing is available. The same thing with a high-carb diet, the same thing with sedentary behavior, chronic stress, sleep deprivation, circadian rhythm disruption, which means that we work on a 24-hour day, and obesogenic medications. And there are more than 50 obesogenic medications that we use for other diseases today. If we want to really fix obesity, and the CB1 antagonists that we are going to be talking about are one approach to doing that, we really have to reverse the underlying physiology that led to the obesity in the first place. These medications have to drive down where the body wants to live in terms of its fat mass. So the goals of obesity therapy then are to improve the quality of life, the efficacy of life, and just simple health as a result of the treatment. Specifically, we know that weight loss can improve obesity and many of its complications, but in addition, we want to improve the symptoms of obesity, which include excess hunger, food noise, craving, inability to get full after a meal. We also have the physical symptoms like shortness of breath without heart or lung disease, just because of physical size. The dysphoria that comes largely from the stigma around obesity, but also can come from just the way people with obesity are forced to interact in the social and economic world. Those types of symptoms we want to improve. We also want to improve the existing complications. I said there are more than 200. There's plenty to work with here. And we want to prevent the future of obesity complications. Obesity also stimulates a multi-system metabolic and inflammatory syndrome, obesity leading to metabolic stress worsening the obesity, and together leading to ectopic or inappropriate fat accumulation in places where it doesn't belong. As I mentioned before, the kidneys, the pancreas, the heart, the liver. Systemic inflammation, cell injury, and fibrosis. And so these can occur in all of these organs shown here, and there are specific diseases in those organs that result from the influence of obesity and metabolic stress. So the ideal therapy then would be safe and tolerable. It would improve cardiometabolic health, liver, kidney, and pancreatic health, and reduce the risk of cancer, more than 15 types of which are induced or made worse by obesity. Now, with the advent of the new, very well-known GLP-1 receptor agonist medications, we now have seen that there's a growing list of diseases that are complications. We used to call them comorbidities, but we realize now that there's a causative effect. So they're real complications of obesity, many of which are listed on this slide. Each one of these has been demonstrated to be significantly improved by treating the underlying obesity. So treating obesity has broad effects on lots of other diseases. But what I want to emphasize on this slide is when the studies were published that proved this. And these studies, look at this, 2014 is the oldest one, that's diabetes, first demonstrated with bariatric surgery. But with the new medications, we see that most of these studies were published within the last 3 years. 4 years ago, we wouldn't have been able to say, we would have been able to say that these diseases are associated with obesity, but we would not have been able to say with confidence that treating the obesity would improve these complicating diseases. And now, in the last 3 years, as you can see on this slide, we can do that. And most of the papers were published in Lancet and the New England Journal of Medicine, the best medical journals that we have. So with these new highly effective medications, including new ones that are emerging, such as the CB1s that we'll talk about, this list is growing very rapidly. So given the size of the problem of obesity, with more than 100 million people in the United States, now estimates are more than 1 billion, as of 2024, more than 1 billion people in the world, or 1 in 8 of the whole world's population. If we're able to overcome the barriers to treatment by having better treatments and having access to those treatments, we should be able to see an impact on obesity at the population level, which we've never seen before. First, a reduction in the severity of the existing obesity, and later a reduction in the rate of obesity, as effective treatments will predict effective prevention strategies. Right now, we've not been able to prevent obesity no matter how hard we try, because we view it as a one-size-fits-all disease. And prevention, of course, is reflective of the disease itself, which means that now that we know that obesity is heterogeneous with different causes in different people, we are going to need effective treatment strategies to also provide prevention. We should see an improvement or reduction in the major complications of obesity, and the ones we focus on most are the metabolic ones: diabetes, heart disease, kidney disease, liver disease, and obesity-associated cancers. We should see significant advances in mental health and quality of life, because those are also complications of obesity, which may lead to beneficial effect on social capital more broadly in the population. Because obesity is so prevalent, the effects on individual patients are translated into effects on the whole of society. Similarly, we may see a reversal of the recent trend toward reduced life expectancy that's been happening for the first time in the last century, where we've seen a reduction in life expectancy, which has been attributed in large part to the increasing rates and severity of obesity. We may see a decrease in healthcare costs, just because treating the underlying disease is always a principle of medicine, that we treat the underlying disease rather than the symptoms of a disease. We may see an improvement in economic productivity, because obesity has a downward puts downward pressure on the economics of an individual, with less education, less of a job for the same education, less pay for the same job, less opportunity for promotion. And when you have a whole society that has a high prevalence of obesity, it has a downward pressure on the economics of the whole society. We may see food industry incentives moving from quantity to quality as patients are less hungry, are eating less, but want better food. All of these changes would be predicted to generate the greatest benefit in populations with the highest current rates of obesity, which are the populations that are underserved in many ways in the healthcare system and in society at large. But this only works if the access to obesity care is both sufficient and equitably distributed. That is also not the case. And so the more and better medications we have, as opposed to being limited to effective therapy with surgery alone, gives us the opportunity to improve that equitable access to care that has not been available to the whole society, even in the United States. I'll stop there and turn it back over to our hosts.
Thank you, Dr. Kaplan. All right, we'll turn it over to Dr. Twitty and Dr. Gonsalves. They're going to cover the introduction to nimacimab as well as the scientific rationale for peripheral CB1 inhibition. So Chris, you can take it away.
Thank you, Puneet, and good morning, all. I'm going to spend just a few minutes providing a background and some context for the CB1 axis in terms of obesity, as well as provide an overview of our CB1 inhibitor, nimacimab, before turning it over to Dr. Gonsalves to dig into some of the metabolic pathways of peripheral CB1 inhibition. So echoing what Dr. Kaplan just walked us through, obesity can be defined as an excessive fat deposition that impairs health, simplistically driven by a biased relationship of food intake relative to energy expenditure. But more specifically, it is a complex disease characterized by metabolic dysregulation that promotes inappropriate hormone expression, increased adipogenesis, and chronic inflammation, which can all act in concert to drive this pathological state. What's becoming more and more evident is that CB1 plays a critical role in this metabolic dysregulation. So the CB1 axis has two principal players, the receptor and the ligand. The receptor, of course, is cannabinoid type 1 receptor, or just CB1, and the ligands are endocannabinoids. These are lipid-like molecules, principally anandamide and 2-arachidonyl glycerol. And so this axis, when engaged, globally favors intake and conservation of energy across diverse tissues and organ system. And when thinking about this in terms of an environment with resource scarcity, this was a huge advantage to really our survival. But we all live in an environment with an abundance of food, and so this axis now promotes pathology and helps drive obesity. So the CB1 axis, that's both the endocannabinoids and a receptor, is highly active in obese as well as fasting states and does promote adiposity. When thinking about blockade of CB1, this helps to not only reduce caloric intake, but there are additional metabolic gains that can happen in peripheral tissues. And so this brings up the question of central and or peripheral CB1 inhibition, what is required. And so if we think about the brain, we know that there's an incredibly high concentration of CB1 there. And this is blockade in this central compartment. We know that helps drive anorexigenic pathways, but it's also plagued with the potential for neuropsychiatric adverse events and ultimately halt the development of these first generation inhibitors, notably Sanofi's rimonabant. However, CB1 is also expressed throughout the periphery and controls key metabolic pathways that are addressable with molecules such as our nimacimab. And so with more and more preclinical and even early clinical data, it's clear that there is a sufficiency of peripheral restricted inhibitors that can help to drive weight loss. And these second generation peripherally restricted molecules continue to demonstrate metabolic gains beyond these anorexigenic effects. So I'm going to just pivot for a minute before digging into some pathways relative to that last observation and provide a little bit of background on our nimacimab, which is a first-in-class peripherally restricted CB1 inhibiting antibody. This antibody is a fully humanized engineered IgG4. It's quite stable with a half-life of 18 to 21 days. And there has been a single mutation introduced into the hinge region to prevent antibody Fab exchange. We'll get into this a little bit more in a few slides down, but it's highly restricted to the periphery. So we have multiple NHP studies that have demonstrated very low levels of this antibody in the CNS and brain. And this is true even with multi-dosing schedules. The antibody is specific for CB1, so it's selective only for CB1 and not other G protein coupled receptors. It binds allosterically and inhibits CB1 signaling independent of binding of CB1 agonists. I'll get into this in the next slide, and there's a nice schematic to help illustrate that. Importantly, this is a very potent inhibitor, and it functions not only as an antagonist, that is, it blocks the CB1 receptor in the presence of a CB1 agonist. And this is read out through beta-arrestin endpoints, even cyclic AMP endpoints. But importantly, it can function as an inverse agonist. So that is, it signals contrary to a CB1 agonist. And it does that without a CB1 agonist being present. In fact, it's about twice as potent as rimonabant in an inverse agonist assay. So just want to highlight that. It's very different than a neutral agonist, which does not really measure any type of inverse agonism. So this is a schema, a simple cartoon to illustrate the unique inhibition of CB1. Here on the left, you can see what a productive CB1 signaling would look like. There's engagement of the endocannabinoid shown here with 2-AG or anandamide. There's a binding in yellow at the orthosteric site, and this allows for a productive CB1 signaling, in this case measured through downregulation of cyclic AMP. If we look to the right, you can see some models of how small molecule inverse agonists or nimacimab act. So in the middle panel, there is competition for the orthosteric site. So looking at an inverse agonist here on the left versus the endocannabinoid, the gray ball, both are looking to bind to the orthosteric site. So this competition typically is won out through the inverse agonist, but that's not always the case. I'll come back to that in just a second. On the right, we can see that our nimacimab antibody binds to the allosteric site and is able to inhibit the CB1 receptor independent of binding of the endocannabinoid. So we believe that functionally, these both when the inverse agonist and our antibody are inhibiting CB1, they're fairly similar in terms of potency. However, this competitive inhibition, so competing with the endocannabinoid, may play a role when the endocannabinoids are upregulated, such as during a fasting state or, for example, during obesity. And so you can get high concentrations locally of the endocannabinoids. And if the inverse agonist needs to be potentially dosed down to a lower dose, maybe to overcome some type of safety overhang, this competition may be relevant and impact the therapeutic window, which, of course, our antibody won't have that same issue to contend with. So we think there's a potential positive differentiation there. Okay, so I'm just going to highlight briefly a few key mechanistic pathways that we think are very important. And we think about interestingly, appetite hormones as being one of the key components. So we know that engagement in the CNS can help drive, as I mentioned, the anorexigenic pathways. But this can also happen through peripheral CB1 inhibition. And this works via these appetite regulating hormones, notably CCK, ghrelin, leptin, and even GLP-1. So these can safely promote hypophagia, and we believe this to be a fundamental mechanism to support limited caloric intake in fasting states that are part of an obesity program. We also look at the white adipose tissue. So this blockade in this tissue promotes lipolysis and increased energy expenditure while reestablishing productive levels of adipokines, notably adiponectin, as well as blunting of non-productive inflammatory cytokines. Relatedly, control of hyperleptinemia, we think is very important, and restoration of this really important axis is key to long-term weight loss. Also, reversing insulin resistance is not only important for a potential comorbid population, that's pre-diabetic patients, but also helps directly in obesity by limiting lipogenesis and fat storage in the liver. So it's my pleasure to introduce Dr. Marcos Gonçalves, who's going to touch on some of these and other related peripheral mechanisms of CB1 inhibition. Dr. Gonzalez is a metabolic expert. He's director of systemic metabolism research and an associate professor of medicine at NYU. Dr. Gonzalez, please take it away.
Thank you very much, Chris. Bring up the slide control here. Are the slides advancing on your end?
We're in the scientific rationale slide, Dr. Gonzalez.
Yes. Sorry about that. I'm clicking the button, but it doesn't seem to be advancing. Maybe you can advance?
Sure. Oh.
Okay. I think this is working now. I can advance. Well, thank you very much for that introduction. And some of these content has been previously reiterated by Chris and Dr. Kaplan, so I will be brief. But on the surface, the regulation of body weight is actually quite simple. You have this intake side, and then you have this output side. And when you have an imbalance between the two sides, then you either gain or lose weight. And there has been advanced pharmacotherapy and also lifestyle approaches that have tried to uncouple the food intake and energy expenditure in order to promote weight loss. For example, calorie restriction, incretin mimetics, opioid antagonists have all been used to suppress food intake. Lipase inhibitors and glucosidase inhibitors have been used to prevent nutrient absorption in the intestine, and both of these strategies produce weight loss. On the contrary, there are pharmacologic therapies out there that are aimed at increasing energy expenditure, such as the MC4 agonist and sympathomimetics, and also compounds that help promote nutrient excretion, such as SGLT2 inhibitors, and these may also contribute to weight loss. There is a coordinated neuroendocrine multi-organ response to weight loss, as Dr. Kaplan mentioned. Here I'm showing in just more detail some of the key organs, hormones, and metabolites that help facilitate that coordinated effort to mobilize stored nutrients in adipose tissue, release them for the rest of the body in times when food intake is low or energy expenditure is high. And also these hormones and neuroendocrine system were designed to help prevent further weight loss and promote weight regain. And some of these changes include reduction in thyroid hormone, which suppresses energy expenditure, changes in skeletal muscle efficiency, which helps prevent further energy loss, changes in incretin hormones, and changes in adipokines, such as leptin being suppressed. And all of these help drive hunger and reward pathways that promote weight regain. I also want to highlight that many of these organs that are critical to regulating this neuroendocrine response also express the CB1 receptor, suggesting that it plays an important role in coordinating this effort. Some of the first evidence we have is from rimonabant, showing that using a systemic inverse agonist can reduce food intake and increase energy expenditure. And some of that data is shown here. On the left, we have animals that are on a high-fat diet. Those are the gray boxes. You can see that their weight is higher than animals on a low-fat diet, which are the open circles. And then when you begin treatment with the systemic inverse agonist, you suppress body weight. This has been shown to be due to a reduction in food intake and also an increase in energy expenditure, which is shown on the right. So in this study, rats were fed a Western-style high-fat diet, which is essentially called here the candy diet, because it also has high sugar, and they gain a lot of weight. And here's the 24-hour measures of energy expenditure, and the upside-down triangles and the circles are the animals on either the low-fat or the high-fat diet. And these overlap in terms of energy expenditure because this graph happens to be normalized per body weight. And so that is just a normal response, low during the day when the animals are sleeping, high at night when they're active and eating. When you give rimonabant and you suppress body weight, you actually get this paradoxical increase in energy expenditure, which you could see as the black circles, much higher than the open shapes. And this is different than the normal physiologic response to calorie restriction or weight loss as demonstrated by the animals that were pair fed. So these were animals that were fed the same amount as the rimonabant treated animals to control for that reduction in food intake. And when you do that, the animals lose weight and actually the energy expenditure goes down. So this highlights the dramatic difference between blocking CB1 versus just doing calorie restriction. You get these dramatic changes in energy expenditure. The first hints that peripheral endocannabinoids were important for this process came from this study, which highlighted animals that were fasted or starved of food, and you get a very dramatic increase in one of the endocannabinoids in the small intestine, but not in the brain. And because this is increasing over threefold, its physiologic relevance was further interrogated. And there was a study done where animals were treated with rimonabant, here listed as SR on the right. And you can see after that treatment, food intake is suppressed. However, if you ablate the peripheral sensory neurons in the intestine only, not anything to do with the brain, only targeting the intestine, you no longer get that suppression in food intake from rimonabant. And this data suggests that the peripheral intestinal sensory neurons, which is also where the CB1 receptor is located, are critically important for this reduction in food intake. There are a few ways we can manipulate animal models in order to distinguish what are the central processes, what are the peripheral contributions when you give different compounds. And one of the approaches to this is by designing peripheral brain-sparing compounds, which are shown here in the lilac stars. You can see that these agents only target the peripheral organs, but are not targeting the central CB1 receptor in the hypothalamus. And you can compare what happens when you give these peripheral agents to what happens when you give a systemic agent, which is allowed to penetrate the brain, showed in the deeper purple color. Here's an example of such an experiment where animals were given this compound WIN55 and some more numbers. I'll just say that that is an agonist to the CB1 receptor and acts to mimic endogenous endocannabinoids. And one of the processes we know is due to the CNS effects of this receptor is a reduction in physical activity, also called hypomobility. So when you give the WIN compound, you suppress ambulatory activity, you suppress spontaneous activity. When you give rimonabant, which blocks everywhere in the body, including the brain, you can completely block this effect of the WIN compound, and you don't get the reduction in ambulatory activity. However, when you give a peripheral only inverse agonist, such as this AM compound, you cannot block this effect. And the WIN is shown to have only an effect in the CNS because all the peripheral receptors are blocked. And conversely, you can show that you can block peripheral only effects such as GI transit. And that's measured here in animals by measuring the colonic propulsions. Don't get me into how they do this experiment, because it's not pleasant, especially in the morning as everyone's waking up, but it's easy to measure colonic propulsions. And you can see that the WIN compound dramatically increases the rate of colonic proportions. And when you give the AM a peripheral only inverse agonist, you can completely suppress this effect. And so giving a peripheral inverse agonist also mimics some of the effects of giving the systemic agonist. For example, you get a reduction in food intake, you get suppression in body weight gain. And if you do that pair feeding experiment where you match for the amount of calories that the suppression in food intake is giving, and then you give the compound, you can see that you get this additional weight loss, which is shown on the right in the upside down triangles. And that suggests that food intake alone is not enough to contribute to explain all the weight loss. And there must be an increase in energy expenditure, which I'll show in a couple slides. Another somewhat surprising result, but exciting result, was the peripheral CB1 inhibitor can completely reverse leptin resistance. So it's well known that high-fat diets promote leptin resistance. The leptin doesn't work anymore to suppress food intake, and you can continue to gain weight. And so this was an experiment on the left where animals were fed a low-fat diet or a standard diet, STD, or they were fed a high-fat diet to become obese. And you could see they were then treated with leptin. And when you treat with leptin in the low-fat animals, you get some weight reduction and reduction in food intake. When you do that same experiment in animals fed a high-fat diet who have leptin resistance, you no longer get a suppression in weight change. And when you give the peripheral inverse agonist, you now restore the beneficial effects of leptin on weight change. And on the right, we see the actual hypothalamic signaling of leptin demonstrated by phosphostat-3. And in the standard animals, the dosing of leptin increases the abundance of phosphostat-3, showing active leptin signaling. This does not occur in high-fat fed animals. And then again, this is restored when you give the peripheral CB1 inverse agonist. There is an alternative strategy to tease apart what are the peripheral effects and what are the central effects, and that is by genetically manipulating the animals to not have the CB1 receptor in a specific organ. And here in this example, I'm showing removal of the CB1 receptor from the adipose tissue. And if you give a systemic agent, now the agent can work everywhere, but you don't get the effect that is specific to the adipose tissue. And so I'll show you an example of some of that data. This was a very dramatic effect where you remove the CB1 receptor from only the adipose tissue, and then you put the animals on a high-fat diet, and you can see in black, animals are gaining weight on the high-fat diet. However, if you do not have the CB1 receptor in the adipose tissue, you are prevented from gaining weight. And that's also demonstrated on the right, which is body composition imaging of the animals. And on the low-fat standard diet on the top left, you see a normal amount of adipose tissue highlighted in red. When you put those animals on a high-fat diet, you get much more adipose tissue. And when you delete the CB1 receptor from adipose tissue, you now have much less adipose tissue, even on the high-fat diet. You cannot put on body fat when this receptor is not present in the adipose tissue. This effect is due to a reduction in food intake. So those are the red bars on the left showing less food intake either on the standard diet or the high-fat diet. If you do the pair feeding experiment, you still see much less body weight gain over time, suggesting it's not only a reduction in food intake. And indeed, when you measure energy expenditure directly in the animals using indirect calorimetry, you can see that animals that do not have the CB1 receptor in adipose tissue have much higher energy expenditure over the spectrum of body weight, which is a normal response, a linear response. And this paper go on to further show that this increase in energy expenditure was specific to enhanced sympathetic innervation in the adipose tissue, which is probably driving lipolysis and probably some browning. There are several other studies that I don't have time to get into in detail. However, I highlight their results here. I mentioned the specific removal of the CB1 receptor in the adipose tissue, which reduces food intake, increases energy expenditure, leads to the reduction in loss of fat mass and reduced leptin. If you remove CB1 from the liver, you have a high insulin sensitivity. You develop less liver fat steatosis despite having obesity, and you develop less leptin resistance. If you remove CB1 from the epithelium of the GI tract, you have a less preference for fatty foods, and you have slower gut transit. And if you remove from muscle, this is the most exciting from my point of view, you have actually a high food intake despite normal body weight, again, suggesting a high energy expenditure. You have improved overall insulin sensitivity, and you have an improvement in endurance, so you can run much longer in the animals. So overall, just to summarize the preclinical data, the blockage of CB1 in peripheral tissues can reduce adiposity and caloric intake and increase energy expenditure. This data provides a strong rationale for additive therapeutic benefits, even when combined with the GLP-1 receptor agonists. And modulation of this peripheral CB1 pathway is a fundamental therapeutic approach to address obesity. And I'm looking forward to working with a team to develop a research plan to further understand the role of these peripheral CB1 receptors in obesity.
Excellent. Thank you so much, Dr. Gonsalves. That was a great overview. As a quick aside, I just want to note that when we first engaged Dr. Gonsalves, it's clear he was an expert at translational metabolic research, but I would characterize his potential skepticism, let's say, in peripheral CB1 inhibition. It was very encouraging to see as he read more and more the literature that he became more bullish. And so anyway, it was delightful to see him become a proponent, and we're really looking forward to doing that collaboration with him. Thanks again. Okay, as promised, I'm just going to touch briefly on some of the biodistribution and preclinical tox data. We ran a series of biodistribution studies really to confirm the restriction of our antibody to the periphery. And so in the first study, we looked at a 3 mg per kg IV weekly dosing. So 3 doses, you could see either background levels or very low levels. Importantly, this did not accumulate. So we didn't see any type of accumulation despite a roughly 20-day half-life. So this, again, suggesting this is quite restricted. We increased the dose in a separate study to 40 mg per kg, and again, saw very low levels. And just wanted to note that we're looking at the ratio of plasma to CSF or different tissues. And in the third study, again, these are all non-human primate. In the third study, we used the recent macaque. This is a labeled nimacimab where we can do PET imaging. And here, again, you can see a very similar pattern, very low distribution in the CSF or different compartments of the brain. And this is in contrast to what we saw in the liver here at 48 hours. And on the right, you can see some of these images, time course at 6 and 24 hours with very, very minimal distribution, if any, in the brain, but very readily detecting the presence of nimacimab in key tissues and organs, notably of course, the liver, spleen, kidney, as well as others. So we don't really see any type of limitation in terms of its biodistribution within the periphery. Pivoting briefly to the preclinical toxicology package, our NOAEL is excellent at 75 mg per kg, and we think this is a very robust and significant safety window that we've established. So a few studies that went into this. Initially, there was a 75 mg per kg dose that was performed weekly for 4 weeks, and we observed no nimacimab-related tox assessments. Importantly, no neurological observations were witnessed. There was also a 3 as well as a 26-week toxicology study, again at the 75 mg per kg dose. This was administered biweekly, subcutaneous. And again, there was no nimacimab related changes in ophthalmology, EKG, blood pressure, blood chemistry, hematology, or histopath. Again, we've established that 75 mg per kg through both of these studies, and this half-life is present as well as at 21 days with high exposure at the end of study. So these are very important as we stitch this all together, and I think this is a great place to hand off to Puneet to walk through some of our clinical details and strategy.
All right, thank you very much. So yeah, it's my pleasure to have Dr. Lou Aroney here with us today. He's one of the notable obesity experts in the world, and he's going to walk us through his clinical experience broadly, as well as experience with CB1, and as well as touch on our phase 1 data, and then we'll turn it over to Dr. Beverly Chang.
Thanks so much for that. It's very exciting to be here. And I now have control of the slides. Is that right?
Yeah.
Okay, here we go. So thank you for having me here today. I'm very excited to be a part of this program. I'd like to disclose that I am both a paid consultant and shareholder in Skye Bioscience. I'm happy to make all my disclosures available to anybody who would like to see them. I've been involved in studying CB1 antagonist, inverse agonist for a very long time. My first paper was 2006, the Rio North America trial. So I've been a believer in the power of cannabinoid antagonism for many, many years. And our original work was tripped up by the issue of side effects. But I think that this approach of peripherally restricting the cannabinoid antagonism and inverse agonism will obviate many of those issues. if we look at where we are right now, and I love pointing out that I did my first obesity trial in 1989 and have performed well more than 50 trials of different compounds. We now are beginning to see the fruits of the labor of many of us in that we now have 7 compounds available. And these are in several different categories. Some people think that there's going to be a duopoly of Novo Nordisk and Eli Lilly. I personally don't agree. I look at the cardiology colleagues who have dozens of lipid-lowering agents. They have more than 100 antihypertensives. When you look at the complexity of the weight regulating and metabolic control mechanisms, we need many, many more compounds in many different areas in order to be able to completely manage patients in the way that we believe they should be managed. So while the GLP-1s are dominant right now, I think that as time goes on, we're going to see that a paradigm where we maybe combine a GLP-1 along with a compound in a different category that allows us to reduce the dose of the GLP-1 to improve tolerability will be the best strategy. If we look at the CB1 mechanisms, I see them as being complementary to those of the GLP-1s. If we look at their impact, we know that they decrease appetite and improve satiety when they're centrally acting. But interestingly, that can happen as well with a peripherally restricted compound because of the impact on adipose tissue. They may have an impact on gastric emptying, and they may have an impact on stimulating insulin secretion, but the most important ones are the improvement in insulin sensitivity, and in my opinion, leptin sensitivity, which by itself should be a weight-losing strategy. Preserving lean mass, which I believe is related to the improvement in leptin sensitivity, and greater GI tolerability than the drugs that we currently have available. So I think that there are a number of ways that the CB1 antagonist compounds that are peripherally restricted can fit in with the drugs we currently have available. If we go back to the old days, looking at the clinical validation trials of the first generation drugs, we saw very good weight loss, first generation weight loss compared to what we have now, not as good, but these drugs worked and achieved improvements in the cardiometabolic outcomes. But they were derailed by an increased risk of depression and suicide that was related to one trial in particular, which was being run by Sanofi. Some of us who were involved did not believe that that was necessarily there in the magnitude that was described, but was really related more to the management of the trial and their approach to it. But be that as it may, we should not have those problems with a peripherally restricted agent. But again, I see this as a compound and mechanism that can have an additive effect and a very important separate metabolic effect from the GLP-1 agonists. And if we look at the compound that is out there right now that has probably the furthest along, it is a compound from a company called Inversago, which was purchased by Novo Nordisk. And that compound achieved a 3.5 kilogram weight loss after 28 days in a phase 1B trial. It was safe and well tolerated with a very low incidence of neuropsychiatric side effects. And it is now moving into a phase 2 trial, into a large phase 2 trial. And I believe we'll see this moving forward in the very near future. So I am enthusiastic, and the fact that Novo Nordisk is interested in it, of course, gives this mechanism greater validity because I believe they know what they're doing, probably more than anybody out there. So if we look at the nimacimab phase 1 data, We're going to be talking about their single ascending dose trial and their multiple ascending dose trial. These were in the single ascending dose, 0.6 milligrams per kilogram, 1.2 and 2.5 milligrams per kilogram administered IV over 30 minutes. And then in the MAD, 82 patients with NAFLD, many of whom had diabetes and pre-diabetes, and with a similar treatment paradigm. And the results showed a PK of 18 to 22 days. It showed a good level of safety with no neuropsychiatric side effects and good tolerability. The average weight was slightly lower or was maintained in all the treatment groups through the end of dosing, but there was not a striking weight loss. The placebo group showed a slight increase in weight over the visits, and at the end of the 45-day follow-up, there was a striking increase in body weight. Of great importance, there was a reduction in LDL cholesterol at day 67, and the reduction was 7.4% versus an increase of 8% in the placebo-treated group. So a 15% relative change, which I believe is significant. And then there were significant changes in hyaluronic acid along with other trends in inflammatory and fibrosis markers. And the area of fibrosis is a very, very important one, because when we look at the impact of the current GLP-1s on fatty liver disease, one of the big issues that we keep getting asked in our trials of these drugs in that setting is, are you going to be able to improve the fibrosis? And mechanistically, I don't believe that we will be able to improve fibrosis with GLP-1s, but it looks like the CB1 antagonist, inverse agonist, may be able to have an impact on fibrosis markers, which I think would be very well received by many. So why did we not see this significant weight loss in this phase 1 NAFLD trial? And there are a couple of potential reasons. On the right, I'm showing a slide of the CAGRI-SEMA phase 1 trials, which were 20 weeks, and then there was a 5-week follow-up. And you can see that several arms of this trial showed no weight loss during the first month of treatment. And CAGRI-SEMA looks like it could ultimately produce 30% weight loss. But several of the arms with low dose cagrilintide and the standard doses of semaglutide during the titration phase had no weight loss, and in fact, weight gain, so that there was a higher weight over a month's time compared to even the placebo. So we see this in phase 1 data on a regular basis. The fact that we were dealing here with not only NAFLD patients who tend to lose less weight, but also with patients with diabetes, 83% had diabetes, they lose less weight. And in many of these trials, we have young men who are domiciled who tend to try to figure out what they're on by eating as much as possible. To, they want to see if the medicine is going to stop them from eating. It's the best way to describe it. It's very, very possible that that is the situation that Skye had in this particular trial. So this does not impact me in any way in my decision about whether this is going to cause weight loss. Novo studies, they have a number of studies in patients with diabetes showing reduced levels of weight loss as a result, and some as little as 4% and 6.2% weight loss over a 6-month period of time. 3.9% at 3 months, 6.2% at 6 months in subjects. And so again, there is tremendous variability, and in a group of subjects who are heavily diabetic, it is entirely possible that you could see no weight loss, even though the compound will produce weight loss. And I would say that the LDL change to me is very encouraging. We've seen that with a number of trials of the dual agonists. It's a very, I don't want to say it's an early marker of weight loss, but we've seen that, and that gives me some enthusiasm. So once again, I do not believe that not seeing weight loss means that there is not going to be weight loss as we move forward. So if we look at the future, we're going to be able to address unmet needs like accessibility. We realize that there just can two pharma companies handle the demand, the worldwide demand for these compounds. I don't believe so. What about sustaining weight loss? There are many different approaches that are going to work. The safety and tolerability, while many people do extremely well on these compounds, not everybody does. And there are broader metabolic events, benefits that can be achieved with compounds in different areas. The future outlook is going to be for oral GLP-1s, GIP and glucagon combos, multiple combos in multiple different ways. And I would say that a GLP-1 and CB1, there's a misprint here. Having CB1s alone and then CB1 in combination with GLP-1s, I think are a very, very reasonable combination. And I think the convenient dosing of a compound like this, improved tolerability, safety profile, and lean muscle preservation, which if you look at the impact of leptin sensitizing alone, we have evidence from previous work of many years ago showing that improving leptin sensitivity will preserve lean body mass. So I think CB1 inhibitors are a very promising generation. I think that a 5 to 8% reduction in weight will be enough when added to other compounds in the field. And many of the patients who we see don't need to lose 25% of their body weight. And so I see many areas where a compound like this could be of great value. So thank you very much for your attention. And
Thanks, Dr. Roney. All right, that was a great overview, and we're going to kind of drill into the safety side of phase 1 with Dr. Chang, and also Dr. Chang has a lot of firsthand experience here because she's been a treating physician and sees cases in the real world. We're going to get a perspective of that at the end in the panel session, but I'll turn it over to Dr. Chang.
Good morning, everyone. Working on slide control. I'll say that I am primarily a clinician, and so when Skye Bioscience first approached me regarding this compound, my first question to them was, what is its safety profile? And I would say that when we look at the primary priority of treating patients with obesity, it isn't weight loss, and it's actually not to get them healthier either. It is, number one, to do no harm. And I would say that we see a lot of that reassuring data just from its phase 1 data. So to give, to set the stage here in terms of the overview of our safety concerns with anti-obesity medications, we are hyper-focused on those neuropsychiatric concerns. We've already seen data on how the CB1 agents can penetrate the brain, specifically related to our old anti-obesity medication for Monobond. But Chris had also shown us significant data on how nimacimab does not have any brain penetration. So we'll go into how that might manifest in some of the clinical data. We've mentioned a lot about Sanofi's rimonabant that was approved by the EMA in 2006 and then removed from the market in 2008 due to neuropsychiatric concerns specific to suicidal ideation, as well as anxiety or depression. But again, the rimonabant is significantly different from the current agent because of its brain penetration. And in fact, it was designed precisely for that. Initially, it was designed to be an agent for, I believe, alcohol or smoking cessation. So it was looking particularly to take advantage of dopamine reward pathways, mesolimbic limbic pathways. Nimacimab, as you've seen, has excellent brain exclusion in preclinical studies, which provides a great foundation to avoid those neuropsychiatric side effects. Now, Dr. Aroney gave you the background already of the phase 1 multiple ascending dose trial, in which participants were randomized to placebo versus nimacimab dosed on a weekly basis. And the trial ran for a total of 67 days, with the treatment being day 1 to day 29. This data shown here is actually from the phase 1b. In other words, phase 1a was conducted in healthy volunteers. Phase 1b was conducted in those with diabetes, prediabetes, and non-alcoholic fatty liver disease. What I want to highlight here is, even though we are studying rimonabant as an obesity medication, the phase 1 data from the NAFL participants is actually quite relevant. We see an average age, for example, of 51, which is right on target, actually, with a lot of the recruitment in our phase 3 trials among the obesity studies. We have an 80%, about 80% versus 20% split in those with diabetes or prediabetes. So again, looking at a metabolically unhealthy population. And they do have elevated weight in this study, with a mean weight of around 90 to 94 kilograms among your treatment arms and placebo arms, and a BMI in class 1 obesity of 32 to 33. So again, highly representative of the population we are intending to treat with nimacimab for people with obesity. This slide shows the number of treatment emergent adverse events listed by frequency. So on the very right-hand side, you'll see the column active overall, and the most frequent adverse events are listed according to which one is most common. So diarrhea, headache, upper respiratory tract infections are the top 3 among these groups. The diarrhea has an asterisk next to it, but I don't believe that asterisk footnote came through. You'll find that there was about a 40% incidence of that in the placebo group, and a pretty high incidence among the other treatment arms, likely related to the de novo lipogenesis protocol, in which these individuals were submitted to drink deuterated water, and then were given fructose drinks, and then were measured in terms of their de novo lipogenesis. So this protocol actually has a high frequency of diarrhea and nausea, which is why you see that high percentage in both placebo and treatment groups. Headache, upper respiratory tract infections are actually very common adverse events in all of our clinical trials. Everyone seems to get some kind of cold or URI in clinical trials because they do go on for such a long time. But what I want to really point out from this table is that the top 3 are not gastrointestinal. And if you look at the phase 3 clinical trials among our top anti-obesity medications today, the GLP-1s, the GLP-1 GIP medications, you'll find that the top 3 adverse events are always nausea, vomiting, diarrhea, constipation. And this is not the treatment emergent adverse event profile of nimacimab. I think this is the most important slide, actually, because of the context of rimonabant and the history of CB1 inverse agonists. This Columbia Suicide Severity Rating Scale is validated and the recommended scale by the FDA to assess the spectrum of suicide, that being suicidal ideations, attempted suicide, as well as completed suicide. And you will want to see zeros across the board, of course, which is exactly what you see here. Participants were evaluated at the beginning of the phase 1 study, and then if they had indicated any positive answers to the scale, they were reassessed at day 29. And again, if they gave any indication to a positive answer on day 29, they were reassessed at day 67. You can see here that there were, again, zeros across the board there. So in summary, nimacimab appears to be safe and well tolerated with a low rate of treatment-emergent adverse events and no drug-related treatment discontinuations as far as any of their adverse side effects. Their GI tolerability profile is highly favorable, and this is important because our current leading anti-obesity medications have a GI profile that often does lead to discontinuation to many individuals. And in this phase 1 study, there were little to no gastrointestinal disorder associated adverse events. Finally, and probably most importantly, the neuropsychiatric findings were 0 to none, measured by the CSSRS in this phase 1 trial, and there were no other signs of other psychiatric adverse events. Overall, I would say the take-home point from the phase 1 study here is that we did study nimacimab already in a population applicable to whom we would be studying it in the phase 2 trials. In other words, those with obesity and metabolic disease. We found no neuropsychiatric concerns in the phase 1 trial, an excellent GI tolerability profile, and actually a safety and efficacy profile that is likely to be complementary to our current anti-obesity medications.
Thanks, Dr. Chang. Appreciate your overview. We'll kind of getting short on time here, so we're going to pass it over to Tu, and then we'll open it up for a panel question.
Thanks, Puneet. And before I start, I really want to thank all of our KOLs, Dr. Aroni, Dr. Chang, Dr. Gonsalves, and Dr. Kaplan, for really their insightful overview of the space and our program, and really setting a foundation for me to discuss with you our plan here moving forward with our phase 2 study and potentially beyond. So what I want to start with first is what we believe is nimacimab's target product profile, based on the insightful overview provided by Dr. Aroni in the current state of affairs in the anti-obesity medicine space. And so we think nimacimab really has an opportunity here in obesity with a therapeutic area of patients who are obese or overweight with weight-related comorbidities, and an indication for use as an adjunct to calorie and diet increased physical activity and chronic weight management, which is in line with the current indication for use for GLP-1 receptor agonists. In terms of dose, we do expect at least a once-weekly dosing at a minimum of 200 milligrams of nimacimab, but hope in a ideal situation at potentially a once-a-month subcutaneous injection at a potentially higher dose of nimacimab, which we will be evaluating in the future. In terms of clinical pharmacology, we think a minimum of 5 to 10% weight loss would be sufficient to provide a meaningful weight loss, clinically meaningful weight loss in this population, but hope for a potentially double-digit weight loss, where we'll also see additional gains and improvements in fat and lean mass ratio, improvements in triglycerides, as well as improvements in leptin and insulin sensitivity. From a safety perspective, as Dr. Chang highlighted, we would expect our peripherally restricted CB1 inhibitor to have little to no neuropsychiatric side effects and minimal GI side effects, similar to what we've seen in our phase 1 studies, as well as even with rimonabant. And as we move forward with a proposed clinical program, I'll be discussing with you our proof of concept phase 2 study, which will be starting very shortly. And we expect moving forward to conduct additional studies, namely in phase 2B, where we'd look at a dose ranging and optimization study and moving into supporting for a phase 3 study against placebo for 52 weeks. So before I jump into the actual details of our clinical trial design, I really want to level set and note at a high level the purpose of this first study in obesity with nimacimab that we've coined See Beyond. So first and foremost, obviously, we really want to demonstrate efficacy and proof of concept, and namely, we want to demonstrate that truly peripherally restricted CB1 inhibitor like nimacimab will result in clinically meaningful weight loss. We want to show that there is a clear potential for combination with CB1 inhibitors and GLP-1 agonists, either as an additive or synergistic weight loss tool. And we want to demonstrate lean mass preservation, where we believe, as Dr. Gonçalves highlighted, there is a potential for CB1 inhibition to support lean mass. And importantly, as Dr. Chang highlighted, we also want to demonstrate the safety and tolerability of this drug, in particular around the neuropsychiatric side effects in this space, and ultimately as well related to GI tolerability, since we know today lots of patients are really dropping out of these studies and stopping use of these drugs as a result of these intolerability issues. So with that, I'd like to share with you the protocol design for See Beyond, a phase 2 study of once-weekly nimacimab compared with placebo, and once-weekly nimacimab co-administered with semaglutide in participants who are overweight or obese. So this is a 26-week study where patients will be dosed once weekly on all treatment arms. We'll have 4 treatment arms randomized at 2, 2, 1, and 1. So in the first part of the study, we'll have a double-blinded portion of the study. We'll be enrolling 2 arms, a nimacimab single-agent arm versus a placebo matching nimacimab, and each will have 40 patients per arm. In the second part of the study, it'll be conducted partially blinded, where patients will know that they'll be receiving Wegovy, but they'll be blinded to either nimacimab or placebo. Patients will be followed up for a total of 13 weeks after treatment for a total study period of 38 weeks. So importantly, the primary endpoint of See Beyond here is, again, to demonstrate that nimacimab does lead to significant meaningful weight loss against placebo. So the study is powered to look at the 40 subjects treated per arm in nimacimab, in the single-agent nimacimab arm versus the single-agent placebo arm, to demonstrate a mean weight loss difference of at least 8% between those 2 arms, and the stats are powered to 80% and two-sided alpha. Key secondary endpoints for us are obviously safety and tolerability, neuropsychiatric and cognitive evaluation, body composition is measured by DEXA, as well as key metabolic parameters and biomarkers and triglycerides, insulin sensitivity, and leptin sensitivity. And additional exploratory endpoints, we'll be looking at the evaluation and combination of the nimacimab and semaglutide, looking at the difference in body composition between nimacimab and semaglutide, as well as the difference in safety. So in the question of dosing and why we chose a 200 milligram dose, we did do, and this is the first time we've shared our modeling for nimacimab based on our phase 1 sub-Q bioavailability study that was conducted. In this study, we looked at a single dose, 100 milligram sub-Q dose versus IV dosing, and showed that they were similar. And so based on this modeling, we used a couple of assumptions. One, that there were no inter-individual differences in the model, as well as that there were no anti-drug antibody effects on PK, which is supported by the phase 1 data demonstrating very little immunogenicity in the population. So what this model suggests in the graph or figure on the top here is that the 200 milligram once weekly dose certainly readily exceeds the IC90 expected and gives us sufficient coverage to identify the activity and see activity in this study. What's also important, which is the figure on the bottom here, what we also modeled out is the potential once monthly dosing. And we looked at first the 300 milligram dose, and of course, we feel comfortable potentially even dosing higher given that our established NOAEL of 75 mg per kg. But what we see here is that even with the once monthly dosing at 300 milligrams per kg, 300 milligram flat dose subcutaneously, we do achieve that IC90, well above that IC90 over once monthly dosing. So we're excited for the potential of this and continued development of this potential dosing frequency. Inclusion-exclusion criteria for this study. We will be enrolling, as I highlighted, patients who are obese and overweight with at least one of the weight-related comorbidities listed below. And patients will have stable body weight before entering the study. Importantly, patients will not have diabetes in these studies. So patients who are diabetic will be excluded. As well, I highlight item 6 here, which is important through our discussions with the FDA and planning for this study. Patients who have any history of major depressive disorder, any lifetime history of suicide attempts, or any ongoing severe psychiatric disorders will also be excluded from the study. And this points to and leads into this next slide, which is really about our robust plan to evaluate neuropsychiatric neurological changes and quality of life in this patient population. As Dr. Chang again highlighted, that it is important that we do no harm, that these patients are safe, and we demonstrate a clear safety profile for this, for nimacimab. And so we've outlaid here, we think, a robust plan where we are employing multiple questionnaires and evaluations to really evaluate clearly the safety of this drug, not just using the Columbia Suicide Severity Rating Scale, but also adding in the PHQ-9, which evaluates frequency and severity of depressive symptoms, the SF-36, which is a more general health status, but also includes physical and mental health, the IWQOL, which is a obesity developed quality of life questionnaire, again, that evaluates physical and psychosocial parameters, the PGIS for physical activity, for the purposes of evaluating limitations in a patient's physical activity while on these studies, as well as neurological assessments based on the cognitive DSST test, as well as a robust scripted neurological questionnaire to evaluate the patient's cognitive, motor, and sensory function throughout the study. In terms of key secondary and exploratory endpoints, we think DEXA and scan for body composition is really going to be key for us. So we'll be employing this throughout the study. All patients who are eligible for DEXA will be evaluated by DEXA at baseline, in the middle of the study, and at the end of the study. And I want to take this opportunity as well to introduce that we have initiated a collaboration with Beacon Biosignals. Beacon Biosignals is an at-home sleep monitoring and computational diagnostics company that has developed the Dream headband, which is an at-home, lightweight, easy-to-use headband for in-home polysomnography, which is paired with a oxygen saturation ring, which will allow us to evaluate sleep patterns, hypoxic events, and sleep disturbances in our population. So we'll be conducting a sub-study here of 40 patients in the study. And why are we excited about this collaboration and this evaluation, at least early assessment of nimacimab in patients who are possibly have obstructive sleep apnea? It's because, as Dr. Kaplan highlighted, that obesity is obviously highly associated with multiple diseases, including obstructive sleep apnea. And as I'm sure a lot of us are well aware, Lilly and their Zepbound or tirzepatide recently demonstrated that the associated weight loss with tirzepatide does lead to improvement in sleep apnea. So we do hope and expect in the future, as we continue to develop nimacimab, to continue to evaluate the impact of nimacimab on multiple weight-related comorbidities. And this is kind of our first foray into it, ultimately hoping with the goal of helping patients with their underlying diseases and ultimately leading to expansion of our label in the future. So we think we have a clear development path for nimacimab. We've laid this out here where we do expect our phase 2 study to start again in August of this year. So in very short term, we're looking at interim data in Q2 of 2025 with top-line data by the end of 2025. With that positive data, we'll be initiating multiple activities, not just in the clinical development of nimacimab, in starting to immediately plan for this phase 2b dose optimization study we've highlighted, but also moving forward with a lot of activities that are important for the development of the drug, namely related to our CMC manufacturing capabilities. And we have, again, a clear and robust plan related to this. And what I'll leave you with last is just an idea of what we look to in the future for subcutaneous injection of nimacimab. Currently, we are in prefilled syringes with the safety injection unit by Becton Dickinson. Ultimately, we plan to move to prefilled syringe with an auto-injector. This will be developed in time for a phase 2b study and will be our ultimate commercial product, first commercial product. But in the future, we do want to ensure that we're looking at how to make this drug more easy to use and improve compliance, especially if we're moving into once monthly dosing or even possibly once every 2 weeks, to provide patients with some ease of use and again, to support the compliance of this drug. So lastly, key takeaways, our clinical trial design here provides, I think, a plethora of information to support the future development of nimacimab, not just in demonstrating weight loss with nimacimab, but also demonstrating a combination impact and effect. The endpoints we think are meaningful, where we'll not only show, again, weight loss of nimacimab alone against placebo, but also key safety and exploratory endpoints in body composition and sleep metrics. And as I highlighted earlier, we do have some key upcoming clinical inflection points with initiation of the study in August, interim data in Q2 of 2025, and top-line data at the end of 2025.
Hey, thank you too. That was great. Jam-packed in terms of all the information that we're going to get out of the phase 2 study. At this point, since we have a limited amount of time with the key opinion leaders and panelists today, we wanted to go straight to analyst questions. However, there is some general questions that we felt are important to address. So we put a slide together in terms of just frequently asked questions and just summarizing kind of the key points that were made by the different presenters today. I'll kick things off, I guess, because Dr. Aroney may have limited time. One of the questions that's kind of directed towards the clinical aspect was what do you think is behind the LDL reduction with the nimacimab in phase 1 over such a short period of time and without weight loss? Maybe you can think about that from a clinical perspective, as well as any thoughts you have on the phase 2 clinical trial design.
Sure. It's a great question. Typically, we see a reduction in triglycerides and an increase in HDL associated with weight loss. In the rimonabant trials, we saw an increase in HDL and reduction in triglyceride that was out of proportion to what you would expect with the weight loss alone. So we believe that there was an independent effect, metabolic effect on those parameters. As far as LDL, we did not see a substantial reduction in the rimonabant trials of 19 years ago. So it's in asking what could do it, it's possible perhaps that the improvement in insulin sensitivity or the improvement in leptin sensitivity could have something to do with it. But to be honest, I'm not actually sure.
Okay. The other question, I guess, that's important to address, this is for Dr. Gonsalves. Do you think there's any molecular rationale here for why CB1 inhibition may potentially combat the impact of the GLP-1 agonism on muscle mass? You touched on the CB1 inhibition being very important in terms of caloric restriction and energy expenditure, but just touching on the other aspect of lean mass preservation, I think is a good takeaway that we might want to reemphasize.
Yeah, I think that the studies from the muscle-specific knockout are revealing in the preclinical studies. Anytime you improve insulin sensitivity in the muscle, insulin's a primary regulator of protein synthesis in the muscle, so it's possible that this improved insulin sensitivity is helping protect the muscle from that catabolic signal. And furthermore, if the animals or humans are moving more than they are in their placebo-controlled or pair-fed counterparts, that's also a signal to drive muscle growth and protection from muscle loss. So I think that those two are probably the leading reasons why you see protection of lean mass.
Thank you, Dr. Gonsalves. Tara, do you want to take it over and open it up to analyst questions?
Yeah, thanks, Puneet. That'd be great. So our first question comes from Jay Olson at Oppenheimer. Please go ahead, Jay.
Oh, hey, thank you for providing this update and thanks for taking the questions. I had a few of them. With regards to the neuropsychiatric side effects that were previously reported for early CB1 targeting drugs like rimonabant, can you talk about how soon those AEs were observed following initiation of therapy, and what is the background rate of those side effects that you would expect to see in an obese patient population?
Sure. In the large scale trials of rimonabant, looking specifically at depression or depressed mood as it's defined, it would typically be seen in 1 or 2% of the population, and then it would be double that in the rimonabant treated group. And the other CB1s produced similar results. So I would say 1 to 2% with double the rate in the treated groups was something that was not an uncommon finding.
I will add to that, as far as the rimonabant Rio trials, they did have an exclusion for people who had a background of serious depression or anxiety. And so they were picking out especially individuals who were of lower risk, which is why you see such a low prevalence, that 1 to 2%, even in people on the treatment on rimonabant versus less than 1% in individuals on placebo. The time of onset from trial start to any of those symptoms, whether it's anxiety or depression, ranged significantly from day 2 to day 208. And so of course, the phase 1 data that we have today, extending only out to 67 days, does not encompass the observations that we have from phase 3 clinical trials, which is precisely why we do a phase 2.
Great, that's super helpful. Thank you. And then I guess a lot of investors are expecting, looking forward to the readout from Novo Nordisk's INV-202. Can you just talk about what you'll be looking in that data and how it might read across to nimacimab?
Yeah, so Jay, I think probably we'll take that in the context of I think just how we've looked at designing this phase 2 study and what we're looking at in terms of read through for our expectations, which two highlighted as 8% is what the weight loss that that we've designed this program around. But do you want to elaborate in terms of how we've come up with that particular modeling?
Sure. I mean, I think it's relatively simple. In my mind, at the time when we designed this study, we really looked at rimonabant as our benchmark. So based on the rimonabant data, they showed between 5 to 10% weight loss. Again, at 26 weeks, we think we'll get over that period of dosing, significant weight loss, and rimonabant showed in that range about 5 to 8% weight loss in that 26-week sort of time frame. So we felt 8% was an appropriate weight loss marker for this study design and for this drug over the period of time that we'd be dosing, and provided us with the appropriate statistical parameters to dose the amount of patients that we've chosen to dose.
Great.
Yeah. I think that like on the Novo comment, if they see a good signal in terms of efficacy, we believe that should be the read-through that is applicable for the antibody, as Chris highlighted in terms of the differentiation here and potency still the same from the on-target activity that we expect to generate. So it really comes down to if there's any safety concern that would come out of that signal, and that's something that we're tracking carefully. But in terms of the efficacy signal, I think that would be a very positive thing for the antibody approach.
Great, thank you. Maybe if I could sneak in one last question. Looking ahead to your proof of concept study results in the second quarter next year, will that readout include body composition? And how long do patients need to be on treatment with nimacimab before you would expect to see improvements in body composition versus a control arm?
Do you want to take that one?
Yeah, Jay, I think we're running this study to learn that, to be honest. We're not quite sure. If we look at the if we think about kinetics of the weight loss, particularly with the antibody, I would probably point to some data that we've seen from Versanis, which is a very truly peripherally restricted molecule, but that does not impact immediately impact the CNS through any caloric restrictions. And if you look at that data, the kinetics is really quite different. It takes some time for some weight loss, but they do see that difference in weight loss probably by about, I think they showed about like week 14 or something like that. So maybe that's what we'd see. Ultimately, we're running the study to find out those kinetics and understand those kinetics of weight loss. In terms of the interim analysis itself, we'll be doing it at the full 26 weeks of dosing. So patients will have completed dosing by the time we look at that data.
Great. Thanks again for the update, and thanks for taking the questions.
Thanks,
Thanks for the questions, Jay. So our next question comes from Kristen Kluska at Cantor Fitzgerald. Please go ahead, Kristen.
Hi, everyone. Thanks for this very helpful presentation. I have two questions. First, I understand the complementary nature, how CB1 inhibitors like nimacimab and Wegovy could sync nicely together, particularly with your safety profile. But how do you think about payer and price conversations playing into the potential commercial utilization of combination therapies?
Yeah, Kristen, I can take that. I was going to touch on that in my concluding remarks, but we believe that there is going to be a really an opportunity here to take advantage of the price compression that we expect with GLP-1, given that there's a pretty large pipeline of GLP-1 drugs or other incretin-based approaches. There'll be wide availability. So from our standpoint, we believe our drug can be very well competitively positioned in combination or as an additive to GLP-1. So we haven't done obviously the full modeling but from our preliminary discussions with payers, we believe that there's going to be a competitive pricing. The other aspect of it is obviously looking at some of the comorbidities that are associated with obesity. So part of why we've crammed as much as we can into the phase 2 study design is to look at some of these exploratory endpoints and start to begin to address those in terms of other metabolic related disorders that are associated with obesity. So that is clearly an angle that other pharma has used as well to tackle the paywall.
Thank you for that. And then given you have an advantage here that we've seen a number of obesity clinical trials play out, and to what you discussed in the presentation, we know that some of these patients with comorbidities initially show a lesser degree of weight loss. So I know you briefly touched on the inclusion exclusion criteria for this upcoming study that you're going to start next month, but can you touch to how some of these learnings have really helped design the trial from the standpoint of knowing who are the best patients to enroll? Thanks again.
Do you want to take that one?
Yeah, thanks. Thanks, Kristen. Yeah, I mean, certainly we've learned from the experience with our phase 1 data, and as you said, with the experience that others have shown. I think we've lined up our inclusion exclusion criteria, pretty closely with with these sort of earlier studies that are currently being conducted today, in particular in patients who are obese with some of these comorbidities that won't necessarily impact weight loss immediately, which is why we specifically did exclude diabetic patients in this study, but did include patients who did have some other weight-related comorbidities, including cardiovascular related as well as sleep related. So it allows us to really evaluate weight while also potentially at least have an early look at how nimacimab may impact some of these other comorbidities.
One of the things that happens in phase 2 trials as well as phase 3 trials is there's kind of a land rush to enroll patients in trials like this because people want to get in so badly. And so some of the things that we've discussed are having ways to gate the entry so that we can get the best subjects who are very committed to staying in the trial. You know, those are the kinds of things that we've seen over the years that we've learned from, for example, the Novo Nordisk trials, where they've been able to get, you know, more than 90% retention over very long periods of time, that you can pick subjects who are more committed to the site and to the trial, and you can find research sites that are also committed and have experience. So those are some of the things that I think the Skye team is looking into to try to optimize the outcome of these trials.
Yeah, thanks, Dr. Roney. I think I just want to elaborate on one other clarifying comment around the phase 1, and I know we've talked about the MAD study being focused on NAFLD patients. One of the questions I saw in the portal here was why in the phase 1 did you enroll diabetic patients if it wasn't going to show weight loss? I think that is not the right question. When we're talking about addressing comorbidities with obesity, this is about the phase 2 program and looking at how we can advance the development plan on obesity and address comorbidities. The prior phase 1 program was squarely focused on another development program, another development strategy for NASH. So it's really been trying to put a kind of square peg in a round hole in terms of interpreting how that program and its evaluation with respect to obesity or weight loss, I think is not a fair apples to apples comparison, because that study's intent was not for obesity. So we wanted to make that distinction. So when we talk about comorbidities, it's really about the go forward in terms of how we're designing a clinical strategy going forward. Tara, is there anyone else in the queue?
Yeah, so our next question comes from Albert Lowe at Craig-Hallum. Please go ahead, Albert.
Hi, thanks for taking my questions. My first one is for the clinicians on the panel, and I was wondering how important the retention of lean mass is in the real world setting, and how often the potential loss of it comes up in conversations with patients on GLP-1 therapies.
So the discussion comes up every day. It's now that it's out there, we hear this from patients every day. I don't want to lose any muscle mass. I'm going to lose muscle mass. What can I do not to lose muscle mass? So there are a number of reasons. Our discussion with patients focuses now on dietary interventions and resistance training. If when you look at the lean mass loss, my belief is if we could minimize it or eliminate it, we would have better maintenance of weight off medication. So we might be able to increase the period of treatment, and prolong it. So that would be a great result. But I think that the issue, there's recently been a paper saying this is meaningless, it's okay, this is what happens when you lose weight. I don't necessarily believe that. I think that we're seeing such low food intake in some subjects in some patients taking these medicines, that is the leading cause of reduction in muscle mass. People just aren't hungry, they're not eating enough, and so they're losing muscle. So strategies which could prevent that, I think, are going to turn out to be very, very useful in the future.
I would just add that to what Lou is saying, that this is an area of enormous amount of interest, but also a limited amount of data. And I think that concerted effort to understand this better, which can be accelerated by having drugs like the CB1 inverse agonists would and antagonists would be very helpful in this regard. It's critically important for us to know what exactly the effect of lean mass loss or muscle loss is. Is this appropriate for the amount of weight loss? Is it too much? Is it adequate, or we just don't know? And I think that Lou's points are right on target. We are very concerned about it, but a lot more research needs to be done.
And if I may just comment, my clinical practice also includes patients with cachexia who are experiencing unintentional weight loss and develop severe muscle atrophy and reductions in physical function. Now, am I seeing that with the GLP-1s? No. So it's a spectrum of conditions. We're not getting to the point where these patients are getting horrible cachexia-like syndrome. However, are you getting to this place where you're changing muscle efficiency and that is promoting weight regain? I think that's going to be very much the case, and the CB1 antagonist probably can reverse that and help patients keep weight off.
Great, thanks for those insights. Maybe along those lines, I think Tu mentioned that patients that are eligible for DEXA will be evaluated. Maybe you can tell us what those eligibility requirements are. And maybe similarly, what are other baseline levels of sleep apnea for patients to be included in the sub-study?
Yeah, thanks, Albert. I think the simplest way to put the eligibility criteria is it'll be patients who can fit into the DEXA scanner. There's a limitation to the size of the individual that can fit in DEXA scanner without having to do some manipulations to the scans to sort of piece them together. So we want to make sure that the scans are as accurate as possible. So patients who can fit into the DEXA scanner will get the DEXA scan. In terms of the OSA, the obstructive sleep apnea, at this point we're not specifically asking for any certain level of sleep apnea. We're just looking at patients who have reported medical history of sleep apnea.
Okay, great, thanks. And if I could squeeze in one last one on for the panel on dosing and administration. Now, there's been a lot of attention on developing daily oral therapies for obesity. So I was wondering how much they think patients would prefer a daily oral therapy over weekly injection, and how much a longer dosing interval for injectables would make a difference here as well.
Dr. Chang, you want to take that one?
Yeah, I would say it really depends on the patient. There are some patients who are adverse to needles, and an oral medication is exactly what they need. But we are working with patients with a lot of metabolic diseases, and they're already taking a number of oral pills as part of their medication regimen. And so to reduce polypharmacy, having a once weekly injection has been quite a relief for them. I know that nimacimab is unique because its pharmacokinetic profile means that there could be a potential for once monthly dosing, which is really interesting, I think, for individuals who are in the weight loss maintenance phase. I think there is a population of patients out there who are on a weekly injectable and nothing else is changing about it. They're happy, they're maintaining, and having the convenience of a once monthly option could be really great for them too. So I think having all of those options in the anti-obesity medication space is useful for everyone because of that heterogeneity of need and essentially what patients are looking for.
Thank you, Albert. Thank you, Dr. Chang. Tara, I think that concludes the...
We have one final question. George Farmer at Scotiabank. Please go ahead, George.
Hi, thanks for squeezing me in. Beverly, you mentioned the issue, the potential for maintenance dosing. I was wondering maybe how you can think about exploring that. And also, there's a lot of discussion on mechanism, very helpful. Thanks for all that. But how do you think nimacimab is working? Is it more on the energy expenditure, or is it on caloric intake, or both? Just a little bit of more clarification on that would be helpful.
Sorry, George, can you repeat your first question again?
Yeah, how do you think you can explore the potential of using the drug as a maintenance therapy, particularly in patients who come off of the GLPs for whatever reason?
Yeah, I think because nimacimab is unique in the landscape of medications as having an energy expenditure mechanism means that it can be used for weight loss maintenance. When we look at the risk of weight regain, as Dr. Gonzalez had indicated, those mechanisms are a combination of an increase in hunger hormones, a decrease in fullness hormones, and a decrease in energy expenditure. For example, our muscles actually become more efficient as we lose weight, and that may be one of the drivers of weight regain. The current landscape of anti-obesity medications work to cause weight loss primarily through suppressing appetite, so suppressing energy intake. And we cannot continue to suppress more and more down to 100 kilocalories per day. So we need to be looking at agents that are working on the energy expenditure side to prevent the increase in efficiency, to prevent the reduction in energy expenditure. And I think that's where nimacimab can really play a role with weight loss maintenance and prevention of weight regain.
Okay.
Thank you, Dr. Chang.
Thanks very much. Yeah.
Thank you, George. All right. Gonna keep going here. Just want to wrap up. So obviously there's been a lot of topics covered today, and we'll continue to provide updates with our progress. Our strategy and vision really, has been kind of well conveyed here in terms of we're really trying to focus on combining an innovative approach, positioning us in terms of how we fit into the landscape with our current development strategy. And we look forward to the continued support and collaboration of all of our key stakeholders. I want to once again thank our great panel of key opinion leaders and clinical advisory board, and we're looking forward to working with them. The next steps here now, in terms of where we go from here, I would just touch on the key milestones that we have coming up. I guess one takeaway I do want to state is that we're really focused on rapidly, continuing to develop and advance the opportunities and generate value. In terms of the today, you've heard the preclinical R&Ds ongoing. Additional collaborations that we're focused on with academic centers are expected. Nimacimab is phase 2 ready in follow-on metabolic indications. So we're looking forward to seeing data from the clinical trials as well as preclinical data before we go further. The collaboration that we announced today with Beacon Biosignals will enable the collection of novel sleep disturbance data. And just as a recap, we have about 18 clinical trial sites, including academic centers, that will serve as a part of the phase 2 trial. So it's going to really give us a wide breadth as we continue to develop this program. In terms of upcoming milestones for our obesity program, the next steps include initiating the phase 2 trial this next month with interim data expected in Q2 of 2025. These milestones, along with our GMP manufacturing, non-clinical work, and continuing to advance our metabolic R&D pipeline, we're continue to focus on achieving these with precision and focus. And then to some general forward-looking and to capture kind of the essence of some of the questions that came up today, we do have some, I think, important aspirational targets for nimacimab in the current anti-obesity medication landscape, and obviously that starts with safety and demonstrating clinically meaningful weight loss. but there's really this opportunity in terms of showing improved body composition and seeing how nimacimab can be poised to really establish a stronger market presence, especially when we see that the incretin-based approaches will be widely available based on the current approved drugs, as well as I made a comment earlier in terms of a saturated GLP-1 centric clinical pipeline. So GLP-1 kind of receptor agonists will, we believe, become a widely available as a modality, especially with IP cliffs and generic entrants in the market. And there's a possibility that that causes some more pricing compression for that particular class of therapy, which opens up, I think, an interesting door for CB1 blockade, and it's quite attractive, especially with being a differentiated non-incretin-based modality, and the potentially potentially it showing significance not only as a monotherapy, but as an additive in terms of combination with the incretins. So based on the developing drugs that are targeting CB1 inhibition, we talked about other companies that are doing that as well. There may be a future where nimacimab is among the approved drugs that can be the backbone and the foundation, especially as the anti-obesity medication space evolves. And as we heard today, additional subtypes of obesity or addressing the heterogeneity associated with obesity. So we're looking forward to continuing to build on that foundation that we started with today. I want to thank everybody again for joining us today. Your support, your engagement is crucial, gives us the energy in terms of our mission to transform the treatment landscape for obesity as well as metabolic diseases. And we're really committed to delivering on our objectives and look forward to providing additional updates along the way. Thank you.